A 29-year-old male with Wiskott-Aldrich syndrome, complicated by splenectomy, and juvenile rheumatoid arthritis on hydroxychloroquine presented to the emergency department with 9 days of right-sided chest pain, dyspnea, non-productive cough, and chills. Just 1 week prior, the patient had presented to urgent care with these same symptoms and underwent a CTPA, which was negative for PE, but did show a right upper lobe subpleural mass-like consolidation with mediastinal and supraclavicular lymphadenopathy. Doxycycline, amoxicillin clavulanate, and a 5-day course of prednisone were prescribed. Despite this, his symptoms worsened, prompting representation to our ED. Physical exam was notable for dull sounds in the right upper lung fields, and laboratory data revealed leukocytosis with a white blood cell count of 15,000, as well as mild transaminitis. Blood and sputum cultures were negative. Repeat chest CT showed a nodular opacity in the right upper lobe with air bronchogram versus developing cavitation and marked lymphadenopathy, as well as a hypodense liver lesion. He underwent a right upper quadrant ultrasound, followed by an MRI, both of which were concerning for hepatic abscess. TB-PCR, quantiferon gold, serum galactomannan, beta-D-glucan, and cryptococcal antigen were all negative. Endobronchial ultrasound was booked to sample an enlarged paratracheal node, followed by interventional radiology to drain the liver cyst. Additional antibiotics were initially deferred given the patient's stability. However, he became febrile and hypotensive 1 day prior to EBUS, so levofloxacin and metronidazole were started. Cultures and stains for bacteria, fungi, AFB, leprosy, PJP, and Legionella obtained during the EBUS were negative, but pathology revealed necrotizing granulomatous inflammation. The liver cyst was drained the following day with gram stain showing beaded gram-positive rods, after which he was started on empiric trimethoprim sulfamethoxyl. MRI head was obtained and was unremarkable. Abscess cultures resulted 15 days later with Nocardiosis species. The patient was treated with several different regimens, ultimately finishing a course of amikacin and trimethoprim sulfamethoxyl. This case demonstrates a typical presentation for disseminated nocardiosis and dilemmas in diagnosing this uncommon infection. Nocardia is a gram-positive bacteria which is ubiquitous in the environment. In disseminated illness, mortality can be as high as 50%. Wiskott-Aldrich syndrome made this patient a perfect host for disseminated nocardiosis, which tends to present only with immunosuppression and a particular predilection for those with deficient cell-mediated immunity. Interestingly, neither rash nor CNS lesions were seen in this patient, though after the lungs, the skin and the brain are the most commonly involved organs in disseminated illness. The differential for this patient was very broad, including many other infections as well as lymphoma. Not until histology from the paratracheal node aspirate showed granulomatous inflammation did nocardiosis rise in our differential. This finding, along with gram-positive rods from the hepatic abscess, prompted initiation of empiric treatment prior to the culture results 15 days later. Disseminated nocardiosis can have a very high mortality rate, and with a nonspecific initial presentation, it is important to utilize all data available prior to the return of cultures.